A patient with symptoms of mild depression has been well managed with antidepressants, but is now concerned about the effect of accepting a promotion that will require work in the night shift. What will be your response to address the patient's concern? Is it A, the connection between a new job and possible depression does exist? B, the medication can be adjusted to manage any increase in depression? C, the interruption in normal wake sleep patterns can influence mood disorders? Or is it D, the change in sleep routine can be managed with a healthy sleep hygiene routine? Did you get it? The answer is C. The interruption in normal wake sleep patterns can influence mood disorders. So, why is that? Well, many psychiatric and mental disorders do occur more frequently, or they can be exacerbated when sleep patterns and biological rhythms are disrupted. So, while the remaining options in the question contain true information regarding the management of depression, that is a result of sleep disruption, they do not effectively address the patient's concern. Question two. A patient with depression mentions to you, oh my goodness, my mother says depression is a chemical disorder. Like, what does she mean by that? What's your response? Well, you respond based on the theory that depression is primarily involving the neurotransmitter of what? A, cortisol and GABA, B, COMT and glutamate, C, monoamine and glycine, or D, serotonin and norepinephrine. You should respond with the answer D, serotonin and norepinephrine. One possible cause of depression is thought to pertain to one or more of the neurotransmitters. Serotonin and norepinephrine have been found to be important in the regulation of depression. All right. Question three. A patient asks you if his wife's breast cancer could be caused by her chronic depression. Which response is supported by research data? A, too much stress has been proven to cause all kinds of cancer. B, there have been no research studies done on stress and disease as of yet. C, stress does cause the release of factors that suppress the immune system. Or is it D, there appears to be a little connection between stress and the diseases of the body? Was this one tricky to you? I mean, really, there's no really correct answer, but D would be the most appropriate answer for this. All right, question four. You are admitting a new patient who is depressed. Your initial contact should do what? A, address why he is depressed. B, keep communication open. C, lift his spirits. D, establish trust. Which one is it? The answer is D. You really just want to establish trust. By addressing why he's depressed or trying to just lift his spirits would not be helpful in just meeting for the first time. Though keeping communication open is important, it must begin with establishing trust. D is the answer. Okay, question five. When your patient says, I am depressed, what is the best response? A, we all feel that way now and then. B, why do you feel that way? C, everything will be okay once you just snap out of it. D, tell me more about what is going on with you. They like to put these questions on the test. I mean, the answer is D. Tell me more about what is going on with you. This response gives the patient an opening to share feelings without being pressured to come up with reasons for these feelings. In responses A and C, they're not helpful for someone who is depressed because they minimize what that patient is experiencing. Next question. Biological theories of depressive disorders include all of the following except which one? Is it A, chemical imbalances are responsible? B, the patient experiences maladaptive thought processes. C, there are genetic tendencies that run in families. Or D, hormonal factors make women more susceptible than men. The answer is B because all the others were actually contributing biological factors to depression. The only one is not was B. Your second patient for the day is on trinucypramine for depression. Which of the following signs and symptoms suggest to you that dietary restrictions have not been maintained? Is it A, syncope, B, a hypertensive crisis, D, increased depression, or D, muscle spasms? The answer is B, hypertensive crisis. This medication, trinucypramine, is an MAOI inhibitor. Sorry, it's an MAO inhibitor. It's so eating foods with this enzyme can trigger hypertensive crisis. I included the American Heart Association chart that shows the different blood pressure categories so you know what it is. And it is a good thing to glance at. Know what the normal is. Of course, we know what that is. We know what elevated is. But of course, they did make changes to what stage one, stage two is considered. So for this question, we want to be aware of a hypertensive crisis, and that is a critical situation. That is when the systolic is higher than 180 and or the diastolic is higher than 120. Question 9. You're educating Tina, who's on a tricyclic antidepressant, of the possible anticholinergic side effects. Which of the following is not an anticholinergic side effect? Difficulty starting urine stream, B, blurred vision, C, a dry mouth, or D, muscle rigidity. The answer is D, muscle rigidity. Muscle rigidity is not an anticholinergic side effect. I included this picture so you can know what the different side effects are. Of course, for the eye, it's blurred vision, dry eyes, mouth, dry mouth, because called bowel constipation. Affects the skin. You'll report skin flushing, they're unable to sweat, or they're overheating. Bladder, it causes urinary retention. That means, of course, unable to empty your bladder. The heartbeat can be a little bit more rapid. And then with the brain, they might feel drowsy, dizzy, confused, or even hallucinate. Next question. All right, you're seeing Tracy. She's a 52-year-old patient of yours with a long history of severe depression. And unfortunately, she has not responded to antidepressant medications nor psychotherapy. So, what is the treatment of choice for depression unresponsive to conventional treatment? Is it A, neurolinguistic programming, B, hyperhidrosis, C, electroconvulsive therapy, or is it D, lithium? It's C, electroconvulsive therapy, that ECT. So, though antidepressants are the treatment of choice for depression, electroconvulsive therapy is sometimes needed in cases of severe depression unresponsive to antidepressants. Lithium, that's not generally useful for depression. Light therapy and neurolinguistic programming may be as an adjunct, but it's not the primary treatment in severe depression. Severe depression, unresponsive, ECT. All right. You're doing some patient teaching for Maggie. Um, you started her on amitriptyline, Elavil, for treatment of depression. Which of the following statements suggested by Maggie that more education is needed? Okay, so she can say, even if I start feeling better in a few weeks, I'll keep taking the medication as prescribed. Or is it B? I'll keep some hard candies in my purse in case my mouth gets dry from the Elavil. Or is it C? Once I start feeling better, I'm looking forward to just cutting down on this medication. Or is it D? I'm worried I might gain weight, but that's a small price to pay for feeling better. It's a nice one. C. So once I start feeling better, I look forward to cutting down on this medication. Antidepressants, they need to be taken consistently, including when the patient starts feeling better. So, tricyclic antidepressants like amitriptyline can cause dry mouth. So, that's when you want to educate on. So, I just include this little thing. So, don't forget, with TCAs, there's these 4 things: tachycardia, cardiac effects, which could be increase in the QTc intervals, causing arrhythmia, the A's, the anticholinergic effects, like we're discussing, and S, sexual dysfunction or sedation. So don't forget for the TCAs side effects. All right, next question. So what's the main difference between major depression and dysthymic depression? A, dysthymia is a chronic, low level depression that lasts for years, while major depression is more severe. Is it B? Dysthymia is short term depression and major depression lasts for years. Or is it C? Dysthymia is more likely to be caused by a psychological factors and major depression is caused by neurological dysfunction. Or is it D? Dysthymia is normally treated with psychotherapy alone, while major depression is treated with antidepressants and psychotherapy. Give you a little time on this one. Pause if you're not sure yet. The answer is B. Dysthymia is a chronic, low level depression that lasts for years, while major depression is more severe. So dysthymia is a depressed mood for most of the day, for most days than not, as indicated either by subjective account or observation by others for at least two years. The level of depression is less than in major depression. Major depression is more severe and affects all areas of life. Now, might be a good one. Just write the chart of the differences, and then you'll get it. And this is a nice question. Which statement is most true about depression? A, it's more common in women than men. B, it is rare to have more than one episode of major depression in one's lifetime. Or C, young children do not suffer from depression. What's which one is the most true statement? Was that one tricky for you? The answer is A. Nearly twice as many women as men are affected by depression. Men are more likely to mask depression in other ways, such as substance abuse. The elderly and children are also at risk for depression. So that correct answer is A, women greater than men. Twofold. This can sometimes be in a forgotten population, and I see that in clinic. So this question, you're caring for an older adult who's recently widowed. She says, "No one cares if I die. Everyone I ever loved is dead." What's the best response to this statement that you're going to give? Is it A, I am sure that you still have people who care about you. B, you sound like you're feeling all alone. C, boy, that's depressing. D, I don't believe that. I probably gave it away the way I read the answer. Sorry about that. But the answer is B. You sound like you're feeling all alone. By translating words into feelings, you are like helping her focus on why she's feeling low. Responses A and D disavow her reality, and response C expresses the nurse's sense of being overwhelmed. All right, next question. So, your patient with major depression tells you he's suffering from urinary retention. Which medication would most likely cause this? Is it A, amitriptyline, or is it duloxetine? What about carfentanil? Is that what's causing it, or is it Ritalin? I know you got this one because we already went through this. It's A, amitriptyline. It's a TCA. It's known to cause anticholinergic effects such as urinary retention. So, gosh, definitely want to be careful with this one, especially in our older population. They love these kind of questions. So let's get this one right. All right. So, which of the following meal choices indicate the patient understands the diet restrictions when taking an MAOI? Is it A, pepperoni and pizza? Sorry, pepperoni pizza and beer. B, roast chicken, baked potato and a beer. C, fried fish, rice, and a cola. Or D, pickled herring, eggs, and coffee. Which meal for that MAOI? This is a nice question. The answer is C, fried fish, rice, and the Coca-Cola. So the other responses, they all contain dangerous foods, including like that pepperoni, the bear, and the pickled herring. Next question. Your patient has been taking an SSRI antidepressant for 6 weeks. On arrival at the clinic, which observation would indicate a positive outcome from the medication? A, the patient reports sleeping for 12 hours at night. B, patient reports sleeping 3 hours at night. C, patient reports a weight loss of 10 pounds. D, the patient arrives neatly dressed. 6-week follow up starting that SSRI. What's the positive outcome? The answer is D. The patient arrives neatly dressed. Attention to personal appearance is an important indicator of improved mood. The other responses are not indicative of improvements in depression. Abnormal sleep patterns indicate continued depression. Weight loss can occur with some antidepressants, but would not be used as a measure of a positive outcome. And gosh, 10 pounds? All right, next question. Which of the following is an important intervention for a patient taking nortriptyline? Are you going to make sure that a CBC is ordered to monitor that blood count? Or are you going to monitor for anticholinergic side effects? Or should you ensure that the patient is on a gluten free diet? Or do you want to make sure that they are, push fluids to prevent that dehydration? Which one? Hope you recognize that common thread that's been going on through all these questions, really. It's monitor for that anticholinergic side effect. Anticholinergic effects from tricyclic antidepressants are common initial side effects. All right, next question. So, the wife accompanies her spouse for a follow up visit since you prescribed antidepressant medication. She's asking if there was a deficiency that could have caused his depression. What do you say? Is it A? Well, it could have been epinephrine, norepinephrine, and acetylcholine. Or is it B? Norepinephrine, dopamine, and serotonin could have caused the deficiency. Or is it C? Acetylcholine, GABA, and serotonin. Or D? GABA, dopamine, and epinephrine. The answer is B, norepinephrine, dopamine, and serotonin. So, a current hypothesis regarding the cause of depression is a deficiency of norepinephrine, dopamine, and serotonin, which are all biogenetic amines that are key. They're in the key areas of the brain. Acetylcholine is a neurotransmitter that communicates between nerves and muscles. Epinephrine is a catecholamine that serves as a neurotransmitter that is released in the synaptic branch of the autonomic nervous system and can be hormones when released from cells in the adrenal medulla. GABA aminobutyric acid is a neurotransmitter that inhibits nerve activity and prevents overexcitability or stimulation. Next question on the wonderful TCAs. What is the physiological action of tricyclic antidepressants? Is it to inhibit monoamine oxidase inhibitors that break down norepinephrine? Or is it B, inhibiting the nerve activity, which prevents overexcitability or stimulation? Is it C, blocking the reuptake of serotonin, which increases the level of norepinephrine? Or is it D, it's TCAs inhibit the reuptake of norepinephrine and serotonin? What's the action? TCAs inhibit presynaptic reuptake of norepinephrine and serotonin. So what it does is it causes the accumulation of neurotransmitter that is thought to create an antidepressant effect. Monoamine oxidase inhibitors irreversibly inhibit monoamine oxidase that breaks down norepinephrine and serotonin. Selective serotonin reuptake inhibitors block the reuptake of serotonin and GABA. They inhibit nerve activity. Okay, so next question. Your patient is on amitriptyline, also called Elavil, for depression, but you've changed his medication now to chlormapropine, and the patient's confused, like, doesn't understand why his medication was changed. What's your response? Is it A, these drugs are similar, but some patients just respond better to one drug over the other? Or is it B, well, did you take amitriptyline like you should have? C, maybe it's just the old medicine wasn't working anymore. Or is it D, chlorpromine is newer and will be much better for you? The answer is these drugs are similar, but some patients just respond better to one drug over the other. So because all TCAs are similar and effective, the choice of which TCA depends on individual response to the drug and tolerance of adverse effects. A patient who does not respond to one TCAs, they might just respond better to another drug from this same class. But by asking the patient if he took the medication as prescribed, you're insinuating that he may not have, and that could damage your trust in the relationship. There's You have no basis for commenting that the medication might not be working or another drug would be working better. So the answer is, just try another one. Might respond better to that one within that same TCA family. Next question. A patient comes to the mental health clinic for a regular appointment. The patient tells you that he has been taking oral fluoxetine, 20 milligrams daily for the past 3 weeks, and that he's lost 3 pounds during that time due to loss in appetite. What action should you take? A, teaching the patient about healthy eating to maintain weight. B, congratulate the patient on his weight loss and comment how well he looks. C, encourage the patient to increase his fluid intake to avoid further weight loss. Or D, reassure the patient that a decrease in weight is common adverse effect with this medication. The answer is D, reassuring the patient that a decrease in weight is a common adverse effect of this medication. Adverse effects of fluoxetine have include anorexia and weight loss. Although teaching about healthy eating is a good idea, it's more important to teach the patient how to take the medication in a way that will reduce adverse effects as well as to optimize healthy calories to maintain weight. The patient should actually increase caloric intake, not just fluid intake. The patient should continue the medication to see whether therapeutic effects are obtained and adjust um, nutritional intake if necessary. More information about the patient's baseline weight is needed before congratulating the patient because a patient who's already too thin might not appreciate that comment. All right, next question. A patient's diagnosed with type 1 diabetes and receiving insulin. The physician prescribed an MAOI to treat this patient's depression. What interaction will you assess for with this drug? Are you going to watch for increased risk for hypoglycemia, increased risk for hyperglycemia, increase in appetite, or increase in total cholesterol? It's A, that increased risk for hypoglycemia. MAOIs can cause an additive hypoglycemic effect if taken with insulin or oral diabetic agents. So the patient would have to be monitored closely and appropriate dosing adjustments made. He should be taught about the importance of more frequent blood sugar monitoring because of this. Drug combination in this question would not cause an increase in appetite nor an increase in total cholesterol. So just watch for that hypoglycemia. All right, next question. What drug, if prescribed for the patient, would indicate the need to assess the patient for depression characterized by anxiety and addictive behaviors? Is it A, tofranil, B, phenylphexacin, C, fluvoxamine, or D, paranate? The answer is B, venlafaxine. So venlafaxine, also called Effexor, it's used to treat and prevent depression and generalized anxiety disorder, social anxiety disorder, and it also diminishes addictive behavior. Flufloxamine is an SSRI, paranate is an MAO inhibitor, and imipramine is a TCA, and these are not indicated for treatment of anxiety disorder and addictive behavior. All right, next question. The patient presents to the emergency department with a headache in the back of his head, palpitations, neck stiffness, nausea and vomiting, sweating, dilated pupils, tachycardia, and chest pain. BP is high at 178 over 124 and heart rate 166. The spouse says the only medication he takes is something for depression, but she doesn't know the name of the drug, and the patient is also unable to supply the name. What classification of antidepressant do you suspect this patient is taking? Is it A, MAO inhibitors, an SSRI, a TCA, or an anti anxiety antidepressant? The answer is an MAO inhibitor. The reason is because MAO inhibitors have several serious adverse effects that can actually be fatal. Based on the presenting symptoms, this patient is likely having a fatal hypertensive crisis. This is characterized by the occipital headache, palpitations, neck stiffness, nausea, vomiting, sweating, dilated pupils, photophobia, tachycardia, and chest pain. It may progress to intracranial bleeding and a fatal stroke. SSRIs and TCAs are not associated with these particular symptoms. Anti anxiety antidepressants are not a classification at all of any antidepressant. Next question. A patient with severe depression has been hospitalized and the physician has ordered amitriptyline. What are the common adverse effects to assess for? Select all that apply. A, fever, B, MI, C, stroke, D, dry mouth, and E, gynecomastia. The answer is B, C, and D. When using a tricyclic antidepressant, they can lead to GI anticholinergic effects such as dry mouth, constipation, nausea, vomiting, anorexia, increased salivation, cramps, and diarrhea. The cardiovascular effects like orthostatic hypotension, hypertension, arrhythmia, myocardial infarction, angina, palpitations, stroke, these may occur. Fever and gynecomastia are not normally attributed to amitriptyline therapy. Oh, about three-quarters of the way done. I hope you're learning a lot. All right, with this question is a 10-year-old patient you're seeing for severe depression. Which antidepressant would be safe to give this child? Is it A, trazodone, B, nortriptyline, C, fluvoxamine, or D, phenelzine? The answer is B, nortriptyline. Nortriptyline has established pediatric doses and it can be used in children older than 6 years, but such children should be monitored closely for any adverse effects. Phenelzine is a MAO inhibitor, which is a class of drug that should always be avoided in children due to potential drug-food interactions and the serious adverse effects. Trazodone can be used with children, but it's not the first line because it has many adverse effects on the CNS associated with its use. Luvox is an SSRI that can be used in children to treat obsessive compulsive disorder, but SSRI inhibitors can cause serious adverse effects in children. The biogenic amine theory of depression states that depression results from a deficiency of biogenic amines in key areas of the brain. Why might a deficiency of these biogenic amines exist? A. Slowing of the action of neurons may lead to their depletion. B. Monoamine oxidase strengthens the impact of biogenic amines. Or is it C? The number of sensitivity of postsynaptic receptors may actually increase. Or D. Norepinephrine may be depleted because of biogenic amines that feed off loose particles of the neurotransmitter. Did you get it? The answer is C. The numbers or sensitivity of postsynaptic receptors may actually increase. The three reasons for depression, according to the biogenic amine theory, include 1. MAO may break down biogenic amine to be recycled or restored in the neuron. 2. Rapid fire of the neurons may lead to their depletion. 3. The number of sensitivity of postsynaptic receptors may increase, thus depleting neurotransmitter levels. Next question. Why has venlafaxine become more popular with adults in treating their depression? Is it A, it can be taken orally? B, it does not have adverse effects? C, it can be taken during pregnancy? Or D, an extended release form is available? The answer is D. It's an extended release form. The extended release form is available of venlafaxine. So venlafaxine, what it does is it mildly blocks the reuptake of norepinephrine, the 5-hydroxytryptamine, and dopamine. It has fewer adverse central nervous system effects than trazodone. Its popularity has increased with the introduction of an extended release form that does away with the multiple daily doses that are required for the regular form. Also, venlafaxine is readily absorbed from the GI tract, extensively metabolized in the liver, and excreted in the urine. Adequate studies have not been done in pregnancy and lactation, so that it should be used during those times only if the benefit to the mother clearly outweighs the potential risk to the neonate. It is taken orally, which is the case with actually most antidepressants. All right. You prescribed amitriptyline for depression. What teaching do you provide to help the patient monitor for adverse effects? If chest pain occurs, an over the counter pain reliever will help. B. Nasal congestion indicates a respiratory virus is beginning. C. Measure and record blood pressure daily. D. Adverse effects will subside as you adjust to the medication. The answer is C. Measure and record the BP daily. Cardiovascular effects of amitriptyline include orthostatic hypotension, hypertension, arrhythmias, myocardial infarction, angina, palpitations, and stroke. Miscellaneous reports effects include alopecia, weight gain or flushing, chills, and nasal congestion. Teaching the patient how and when to monitor BP would be an important teaching point. Chest pain could be a serious finding, and patients should be taught to call 911. Nasal congestion is a possible adverse effect of the drug and not an indication of respiratory virus infection. Adverse effects often will not subside and may continue so long as the drug is taken. Next question. A patient comes to the clinic because she is feeling depressed and has gained some weight. You have prescribed oral paranate 10 milligrams twice daily for an atypical depression. When prescribed in this manner, how long does it take for the drug to reach peak levels in the body? Is it A, 1 to 2 hours, B, 2 to 3 hours, C, 3 to 4 days, or D, 4 to 5 weeks? Hours, days, or weeks? The answer is hours. It takes 2 to 3 hours. The monoamine oxidase inhibitors are generally well absorbed in the GI tract, and they actually reach peak levels in 2 to 3 hours. All the other time frames would be incorrect then. A patient is admitted with a presumed diagnosis of colon cancer who takes a monoamine oxidase inhibitor for depression. What drug would be used in case of an adverse effect, adverse reaction occurs? Is it A, epinephrine, B, injectable naloxone, C, phenylalanine, or D, ph- phenethylamine? The answer is D, phenethylamine. So you should have phenethylamine or another type of adreneric blocker on standby when treating in case of an hypertensive crisis. The other options are just distractors to this question. What drug would you consider contraindicated for a patient that's on a monooxidase inhibitor? Is it an SSRI, insulin, acetaminophen, or glucosamine? That should have been an easier one. I think we brought this up already. The answer is A, SSRI. SSRIs are contraindicated because of a life threatening serotonin syndrome that could occur. If a patient requires insulin, the benefit outweighs the risk, but careful monitoring glucose levels is needed because of the effects of insulin may be additive with an MAOI. There's no known contraindication for acetamin or glucosamine. All right. Almost done. Only a few more questions. Hope you're enjoying this. You review a patient who has been taking citalopram for the past 2 years to treat depression. He has felt well now for the past year, and you agree with the plan to stop the antidepressant. How should the citalopram be stopped? A. Stop it immediately. B. Withdraw gradually over the next week. C. Withdraw gradually over the next 2 weeks. Or D. Withdraw gradually over the next 4 weeks. The answer is D. You want to gradually withdraw over the next 4 weeks, so over a month. So when stopping an SSRI, the dose should be gradually reduced over 4 weeks. But this isn't true necessarily for fluoxetine, though. But with paroxetine, you have a higher incidence of discontinuation symptoms. Some of these discontinuation symptoms are increased mood change, restlessness, difficulty sleeping, unsteadiness, sweating, GI symptoms of pain, cramp, and diarrhea, vomiting, and paresthesia. So, following the initiation of an antidepressant therapy, patients should normally be reviewed by a doctor after 2 weeks. For patients under the age of 30 or at increased risk of suicide, they should be reviewed after 1 week. If a patient makes a good response to the antidepressant therapy, they should continue on treatment for at least 6 months after remission, as this reduces the risk of relapse. Oh, wow, only two more questions. I hope you really learned a lot about depression and you'll do well on your test. All right, with this question, a 78-year-old lady is incidentally found to have a serum sodium level of 128 at her annual review. She is asymptomatic and feeling in herself. Which of the following medications is most likely the cause of her hypernatremia? Is it A, irbesartan, B, sertraline, C, democlocycline, or D, gabapentin? The answer is B, sertraline. SSRIs are associated with hyponatremia. Many drugs can cause hyponatremia by increasing the production of or potentiating the action of the ADH. The most commonly implicated drugs include diuretics, especially the thiazides, SSRIs, antipsychotics such as Haldol, NSAIDs, and carbamazepine. SSRIs can increase the release of ADH, and hypernatremia usually develops within the first few weeks of treatment and resolve within 2 weeks of stopping the drug. Older age and concomitant use of diuretics along with SSRI treatment increases the risk of hypernatremia. So make sure you know the side effects of SSRIs. It does have adverse effects to gastrointestinal system. That's the most common side effect. There's increased risk of GI bleeding with patients of SSRI. So, definitely go ahead and prescribe a proton pump inhibitor, especially if they're taking an NSAID. Fluoxetine and paroxetine have a higher propensity for drug interactions. All right, last question. A 36-year-old man presents to you in the office with low mood. Based on what he's describing, he describes anhedonia, fatigue, weight loss, insomnia, and agitation. He scores 20 on the PHQ score. What do? Do you start venlafaxine and refer to psychiatry? You start fluoxetine, start citalopram, and refer for CBT, or do you refer for CPT? Sorry, CBT. C. You start him on citalopram and refer for CBT. The man's PHQ score suggests that he has severe depression. Given the varied symptoms, this would also support the diagnosis. For severe depression, a combination of an antidepressant with psychological intervention is indicated. Guidelines also suggest that the first line antidepressant should be an SSRI. Therefore, citalopram with CBT would be indicated in this case. Venlafaxine would not be the first choice antidepressant, but would be used later down the line if other antidepressants hadn't worked. A referral to psychiatry is also not indicated from the above symptoms. Fluoxetine would be a good choice, first line antidepressant, but guidelines for severe depression suggest that we should combine it with a psychological intervention like CBT. And why CBT? Well, CBD would be a good first line treatment for somebody with mild to moderate depression when it is indicated without antidepressant. However, with this severe depression, the guidelines also suggest an antidepressant should be used in combination of CBT. Watchful waiting, if that's an option, should not be used in this case. That's only good for mild depression, which is not indicated in this case. You made it. If you've gone through all these questions and you know them and understand, you should do well on your test on depression. Comment below if you have any other questions, or definitely comment if there's a topic that was presented in your on your test that wasn't presented in this study guide. Good luck, and share it with your other classmates as well. Thank you.